time to start our grand round. I have to apologize Dr. Sesma because he's in the American Academy, and Dr. Awad woke up sick today. I think I will never replace Dr. Sesma again because every single time of the day he has been calling me and asking me about the well-being of Dr. Sushmita. Anyways, we have this visiting professor, Dr. Sushmita. For those of you that haven't approached to her socially or here in the hospital, you are missing a chance. This is her CV. I'm not gonna read all of this, but the ones that has interest in her, they can read it carefully. Basically, I have to say that she's amazing. She has a lot of interest in glaucoma surgery, pediatric ophthalmology, genetics, new surgeries, and new tools for diagnosis. For me, the most important thing, I'm gonna tell you one anecdote that happens this Sunday. We were watching Dr. Abameflek doing an amazing and difficult surgery on a replace of a tube, and she said to me, "That is a kid." I don't know how many of you, by just simple seeing the eye in the monitor, is able to predict the age. I am not. I called the OR, and they certified that it was a patient of 7 years old. Thanks, I didn't do a bet, otherwise I will lose with her. Dr. Sushmita, it's a pleasure to have you here. Thank you for making this trip, and please, don't waste any more time, and the whole room is yours.
Thank you so much. This feels like home, and it's only my third day here, and I feel that I've been here a long, long time. Thank you ever so much, Dr. Sesma in absentia, but I can assure you Dr. Schlagel and Dr. Dania have taken more than enough care of me, and I'm sure I'm going to put on 5 kilos before I leave your kingdom, which I could do without. Yeah. So thank you very much. And today's talk is on caring for children with glaucoma. I know so little. The more I see them, that every time, every day, I think it's a journey that's just about beginning. So there's no question of the end, because my residents tell me that when we rotate with you in 6 months and we come back to you a year later, you're not doing anything that you taught us a year before. So it's a constantly evolving field. There are no financial disclosures, but we do have taken informed consent from the parents of the children, because I think showing their pictures gives a better context of what we're talking about. So some of these slides you would have seen for those who've come in the last 2 days, but they're all interlinked, so I apologize if there's a bit of repetition. But in today's talk, we'll talk a little bit about what we do at the PGI, where I come from, how it all started, and what we learned along the way. So we've seen this. This is where India, and that's where PGI is. And if we compare statistics where populations are concerned, it's not very flattering to have 492 people per kilometer square to deal with. And if you compare it to your kingdom, it's about 16 people per kilometer square. So it accounts, if you ever visit India, the first thing that will strike you are the numbers and numbers and numbers, but that's the reason. These are the glimpses of PGI. I thought it's important to tell you all that the Postgraduate Institute is a large compound of several different hospitals in all specialities. I mean, it's so big that we couldn't do it in one hospital. So each specialty has a center. That's ours. That's the Advanced Eye Center, and all of them are called advanced. So we have an advanced pediatric, neurosciences, cardiac, trauma, mother and child, and now I think there's one more, communicable diseases, coming up. So each is a self-contained hospital in ourselves. So despite being in the same institute, we possibly don't meet other consultants for many, many months at a time. So these are what I mean by the crowds. These are real-time pictures from outside our clinic. And we realized that the children were lost in the clouds. Often we didn't have enough time, energy, nor the inclination to deal with these babies amongst the crowds of adults that we had. So the PGI journey started with, of course, taking them out. And the first thing that we had to ask ourselves to convince people that we needed a pediatric glaucoma service was to see how many we saw. And this was part of the Indian Childhood Glaucoma survey that we spearheaded, and we looked at new patients in 15 centers countrywide between Jan and December 2019. And when we really looked at all the new patients we saw, it was astounding to us as well, because we were in the thick of it without realizing what we were doing. And if we included the glaucoma suspects, which made up part of our pediatric glaucoma service, we actually saw a total of 618 eyes of 402 patients, which was a huge number, of which, of course, PCG made up about 41%, but the rest of the glaucomas were there, and secondary glaucomas made up a lot. And that sort of sold it. So if you want to sell things to your leadership, keep a number, keep stats, because otherwise it'll be just off your head. We see many, and many makes no sense. So we used whatever we have in the clinic. We set it up. I talked about my journey yesterday, so I'm not going to repeat all that. But right now, we use everything we have in the clinic. So our little children, by the time they're 2 years old, they've learned how to, you see how that little fellow is holding the slit lamp, so they know, they're very well trained. So we take the applanation pressures, we see their discs, we even do the gonioscopies of very small children. The babies, of course, get an eye care in the clinic, and the DSR camera is a great tool for you instead of a slit lamp, because we can just zoom it up and see the phenotype, and we'll come to why the phenotype is important. We use that in the OR as well, and by the time they're about 6, we start putting them on the visual field Humphreys analyzer as well. So 1 day a week, there's us and the babies. It's important having a very child-friendly clinic where the children are at home and the children think you are their surrogate parents, which is what you become. So they're all over our residence and we're good friends. So I'll just talk about some questions we asked along the way and some answers that we gave, and I'll share our experience. So the first thing first, the risk of repeated GA. So remember, it's not a good idea to keep putting small babies to repeated general anesthesia. And there are risk of attention deficit, hyperactivity disorder, language processing, and cognition. And believe me, congenital glaucoma and retinopathy of prematurity are the two diseases which are top of the list for causing this because of repeated GA. And all of us who are in this field have now recognized that and try our best to minimize GA as much as possible. So the first thing that we did was we decided and wondered whether we could really reduce it by using intranasal dexmedetomidine. And this is something which our radiologists and dental people used for sedation of children. So what we did was, number one, it saved us GA time while we were doing the procedure. And number two, the children were monitored because the anesthetist was in the GA room. We don't have a sedation facility like you do. But here you are, you just squirt it through an atomizer, which you get from Amazon for $6. And that's my fellow Deepika, who's made the video also for me. So she's taking Perkins pressure. You can take the CCT, you can do the axial length. You can see the patients post-operatively. You can't do a suture removal, that's a little too, and you would like to do it in the OR. But pretty much our EUAs are taken care of. So we sort of shared this with the world. But now I can confess to having the rebound tonometer, the eye care, and the axial length in the clinic. We rarely need to do sedation. We can make all our decisions with our camera, with our pressure, and with our ultrasound axial length. And this is what the children are like. So they stay sleepy for a long time. So the GA guys, they shake them awake and say, okay, they're all right because they're breathing on their own, but they stay sleepy. So that's how they look at the end of it. So now, as I said, this is what we do. This is a normal axial length chart. And this in the clinic, the right is in red and the left is in blue. And we plot it at every age that they come. And as long as the growth of it is parallel to the normative growth, we know that there's nothing much we need to do, especially if the pressures are fine. And this is how the children are in their lap. This is post-operative. If the corneas get clear, the pressures are okay, the disc seems better, and the axillary growth is okay, we don't do UAs anymore. So, and if the slope goes up beyond what a normative growth is, that's when we take them into the OR to do something. So an example of that is this preterm baby with retinopathy of prematurity. She had lens-sparing vitrectomy surgery, an enlarged globe, and the IOP remained between 12 and 14 until subjectively the pediatric retina surgeon discovered that it was really ophthalmic. And sure enough, when we plotted it, you can see that's what it means by the axial length going up beyond the slope. And then when you do a combined trab with trab, and they come back later, the axial length stabilizes. So that's what you can really do. If we hadn't done it, it would have kept going up. The point is that the pressure remains at 12 because it's like a balloon, which is what I always teach, that a child's eye, a baby's eye is like a balloon. If you poke a balloon, you'll never find it's hard. So similarly, if you check pressures on an enlarging globe, which is very elastic, you're not going to find high pressures. But if you don't check the axial lengths, you'll miss it. So if this baby was possibly in our glaucoma clinic, we'd have caught it before the ophthalmos became so evident. So sometimes the IOP is fallacious because of scarring. So you can see these white corneas with a lot of photophobia, newborn glaucoma, and those are the UBMs. So the white corneas are really, really scarred when it starts in utero. And well, we did the surgery, the photophobia disappears, but the periphery clears a bit, but the scar remains. And if it is still scarred, how do you check the pressures and what do you do? So the axial length shows a slight dip. So this is when they come first. This is when the PSC is not cleared. That is at surgery. So you can see it's really steeply going up. But just as the eye enlarges, similarly, when you do a good surgery, the eye does sort of come back. So you'll realize that it dips and then it goes along. So even with this guy, I don't need to do an EUA because I know that subjectively the baby is better and the axial length has also dipped a little bit. So that means that the pressure must have reduced. So one of the questions was, why do children behave so difficultly? Even PCG behaves differently. You know, there are two babies, so-called same disease, I'm not sure, but look at the difference in outcomes. And this baby lands up like this, and this kid lands up normal. Now, how do you know that? Your parent is going to ask you, is my baby going to see? Is he going to be all right? How are you going to know which baby is going to land up with scarred corneas like this and which baby is going to be perfectly fine? Same surgeon, same surgery, combined trab with trab in both. So the question was, is it just the age of onset, neonatal versus infantile onset, or does the genetics differ? So at that time, and this is like almost 15 years ago, at that time we just had Sanger sequencing after PCR of one gene. It's not the age of next-gen sequencing that you are waking up into, which is so much easier now. But at that time, we had to check gene at a time, and we did CYP1B1 because that was the one most implicated in PCG. And we found in North India CYP1B1 mutations in 46% of PCG, and these were the other variants found in that. And in South India, the mutations were reported in 37%. So we had this background information, and we went ahead and sequenced the CYP1B1 as well as myocilin because there were some reports of a digenic inheritance in some of them. So there were 14 neonatal onset glaucomas and 29 infantile onset PCGs. And we sequenced the CYP1B1 in all of them. And we also did 15 ethnically normal controls with no family history of glaucoma to see whether or not it was a SNP, which means whether or not a variant is normally present in the population. So then if you find that variant in a disease, it is not causative, right? So what we found was, and we subsequently published, was that far more neonatal onset PCGs had a CYP1B1 mutation compared to an infantile onset. So just 6 of 14 versus 5 of 29. So there was a significant difference in the number. And the interesting thing is, we found no pathogenic variant in the myocilin, and yet the R76K of the myocilin was found in the controls as well. So the fact that one report had said there's digenic inheritance may not have been accurate because they didn't check their ethnicity's control population as well. So be very careful that a variant you find may not necessarily be causative because that variant may be normal, which was called SNP in the older days, a single nucleotide polymorphism. Today you call it a benign variant, right? You don't say SNP and mutation anymore. You call them benign and pathogenic variants of the gene. So we also correlated the genotype with the outcome, and we found that in our population, the arginine 390H was the worst CYP1B1 variant to have, whereas neonatal onset babies who had no variant did the best. So if you didn't have a CYP1B variant, CYP1B1 in a PCG, those were the babies who did the best. So rather than find a marker, we found a negative marker, and if we didn't find CYP1B1, we were happy. Now, it's also interesting to note that, remember, our ethnic group, and why is it different in North and South India? Our ethnic group has a proximity to Pakistan. The northwestern India and Pakistan is one ethnic group, really. It's just that politics has divided it through a line. We found nearly identical mutations from reports of Sarfarazi from Pakistan, and the historical reality of the shared ethnicity is evident. And the predominant variant that we had, the R390H, is not reported from the rest of India, but it's reported from Pakistan. So the ethnicity really matters. So that's important. And 63% of our patients who had CYP1B1 mutations had the R390H variant, which was a founder mutation in Pakistan. Right, so the next question was, is it just the age? Because traditionally we were taught that neonatal onset glaucoma is a very, very bad prognosis glaucoma. So we looked at a clinical profile of all neonatal onset, which meant glaucoma presenting before 1 month of age. So we looked at all of them to see whether or not that was true. So if you had only PCG, which means nothing else, no other iris abnormality, no systemic abnormality, just primary congenital glaucoma with normal iris and pupil, they are the ones which did very well, even if they started off as a neonatal onset. So that didn't really matter. The non-PCG neonatal onset were the ones which were refractory. So the rubella, the aniridia, the Axenfeld, the congenital ectropion UVA, these are the non-PCG neonatal onset. So it's not just the fact that they presented at birth or they presented before 1 year, but the fact is what the phenotype is. So that's something that we learned over this. The next is, I had this big argument with everybody because we were again taught that angle surgery will not work in Saudi Arabia, Middle East, and Southeast Asia. Why will it not work in Southeast Asia? There was no evidence. Nobody had done angle surgery. Nobody had really, there was no paper from India or the Middle East which showed that goniotomy failed. But it was a feeling. It was, okay, goniotomy will fail. So you hazard that and you decide, okay, let me do it and see. And that's what we did. So you can see the angle before and the angle after, and that's the cleft. Human beings aren't all that different, actually. I mean, there's some ethnic differences. So this is a standalone goniotomy in a PCG, especially if it's infantile onset. And it's an elegant surgery. You just go in, you make a cleft in it, it opens up. And we had very encouraging results, and we actually decided to publish this in the Indian Journal of Ophthalmology because I wanted Indian ophthalmologists not to go away with the fact that angle surgery is not going to work in Indian eyes. And what we found of success rates of almost 80% for a primary surgery and nearly 70% for resurgeries. Resurgeries meant a goniotomy done after a combined trab and trab. And the encouraging journey was if it was infantile PCG, bang on. There was nothing else that we needed to do. And some of these children are 5 years, 10 years down the line. One goniotomy has worked in all of them. And if you have an infantile onset PCG now, this is what I mean by the second surgery. So, okay, this video doesn't work. But anyway, so they come like that. Oh, there it is. So you do one goniotomy, and it clears a little bit. So it's worked, but it hasn't cleared enough. So you hazard doing a goniotomy in the temporal quadrant as well. So this is after the second goniotomy. So if you did 2 goniotomies, we had 90% success. With 1 goniotomy, it was almost 80%. And that is equivalent to literature which was already published. So it's not that it didn't work. In today's day and age, this has translated into GAT, 360 degrees. So we just do it in one shot, and touch wood, till now we're quite okay with that. The next question was, can we do better? So anything that you do, you have to keep thinking, okay, can we do better than this? So then there's something called BANG, a bent ab interno needle goniectomy, where you just turn the tip of your needle like a reverse cystitome, a 25 gauge needle. We use this to do a bang in every patient of cataract and glaucoma in adults. We do a phaco bang in them. Invariably, there's a reduction in medication by 1 or 2, and they're very, very happy patients at the end of it. Some who were scheduled for a phaco trab, we've avoided the trab, and we've just done it with a bang. So the next question was, let's try and strip off the trabecular meshwork rather than just incise it. And we thought we were being very clever. So this is how the needle is bent, and then it goes the usual way. You go in, and in a bit you'll see the strip of trabecular meshwork which is coming out. So if you see the lower thing, that's the bent needle, and as it goes in a bit you'll see the trabecular meshwork which is stuck on the tip of the needle. So we thought we were very clever. We found children with identical PCG in both eyes, which was the worst thing to do. We randomized them while making the protocol. There you are, that's the trabecular meshwork there, which was stripped off. So while making the protocol, we thought we were being very clever, but it was really, really difficult to get bilateral PCG of exactly the same so that they could be randomized. The same patient had both eyes randomized to either a goniotomy or a bang. So we managed to get 8 children and managed about a year's follow-up in all of them. And surprisingly, it didn't matter. Whether you do a bang or whether you do a goniotomy, both procedures did exactly the same at the end of 1 year, which means that in children, you don't really need to strip off the trabecular meshwork. If you just incise it and make a cleft, if it has to work, it'll work. If it doesn't have to work, it won't work. But doing a bang made no difference at all. So now we come to what we do now. Angle surgery, yes, but we use a GAT, 360 degrees. We don't have the eye track catheter. So we do a conventional goniotomy, take a 5-O-proline with a mushroom tip, which we make with a cautery, a low intensity heat cautery, and then it's just threaded into the Schlem's canal. It does have a bit of a learning curve over the goniotomy, but with so many MIGs coming in and so many people wanting to do a MIG surgery, it's okay. So here you see the other end has come out of the other thing, and you just catch hold of it, and sometimes it slips, but okay, you catch it, and then you pull the leading edge, and there you are. And that's 360 degrees of your trabecular meshwork incised in one go. So this has become our go-to procedure for most of our PCGs now. Okay, let's change track and come to the story where we chanced upon a coexistent cataract in a newborn glaucoma. We weren't really expecting that. The corneas were white, so I was doing the UBM to see what the anterior segment looked like, and lo and behold, a typical nuclear cataract. You couldn't have a more textbook expression of a rubella cataract. And when we tested the child, she was rubella positive, and so was the mother. And it was so unusual that it made it to the cover of the Journal of Glaucoma, and we said, don't forget infections. So this made it. But it also made us think to look prospectively at our newborns. And what we did was we did all newborns who came to us in a year, and we looked at all of them, did rubella testing for all. And surprisingly, the main message from this was rubella positive eyes have smaller eyes. We know that. So if you have glaucoma, which is diagnosed by a white cornea or optic nerve cupping, raised pressures, but the eye is small, think rubella. So that was something which was important to us. The two implications of that is that the cornea is likely not to clear because of rubella keratopathy. And the second thing is, don't forget to look at hearing and heart and cardiac defects, because if you have hearing defects, that child is going to be labeled developmental delay without even knowing that a poor kid is deaf and all he needs is a hearing aid or maybe a cochlear implant. So that's the importance. So now all our newborn babies which come mandatorily are tested for rubella, because unfortunately in our country and a lot of developing country, antenatal care is not standardized and many of the mothers may not be immunized actually. So the cornea didn't clear. So this is a typical rubella keratopathy. You get your pressures low, but the corneas remain white. So they all need an OPK compared to the rubella negative children where the corneas clear completely. And we did find 42%, 3 out of 7 that we found had cardiac defects, and they also had a hearing defect in 1. So now all our newborn children in any case undergo rubella testing, and if anybody is positive, they do undergo a BERA, a hearing, and a cardiac evaluation. So these were our learning points. So smaller eyes and systemic evaluation, those were the 2 important things. So again, change track. This is Sturge-Weber. So this is a previous story really. This 5-year-old boy with Sturge-Weber syndrome and ophthalmos came in 2008. We did the TRAB MMC with shallow choroidal effusions, which resolved. Stayed all right for about 4 to 5 years, required an AGV, stable for a year, had a thick fibrous capsule, which was excised, and then the mayhem started. So this was the kind of exudative retinal detachment and choroidal detachments that we were stuck with. You could see the retina through the pupil. Yesterday at dinner, somebody was relating it, and I was remembering this baby and how it sort of, it breaks your heart because you've done something and this is what they come with. Nobody wanted to touch him. But we'd read about propranolol being given for infantile hemangiomas, and it had just been published in the NEJM. So we took a leaf out of that book because we had choroidal hemangiomas as well. And we asked the pediatrician and the pediatric cardiologist, and they said, we don't see why not, because all children with infantile hemangiomas of the skin are getting the same dose. So we gave the same dose, 2 milligram per kg in 2 divided doses. And lo and behold, it took about 4 weeks, and there it was. Voila. It just melted away and disappeared. And of course, this was so funny that it made it to JAMA immediately. They said, wow, I mean, this was something, and people started talking about it. So of course, the criticism or the limitation was one-off case. You don't know if it's spontaneously cleared. You also gave steroids. You also gave all sorts of things. So I said, okay, let's give it preoperatively. So I was so scared of Sturge-Weber that I started giving them preoperatively, and it's rare enough, so you can't do an RCT. So I did a historical control. I collected all the babies and children that we had who were without propranolol, and I compared them to giving a pre-op propranolol. And we only had 3 peripheral self-limited choroidal effusion in a repeated surgery. For primary surgery, we had 1 versus 5 in the historical controls. Sight-threatening, we had 5 in the historical controls and none in ours. And then we thought we were brave enough to go and tell the world. And I'm very, very happy to share that preoperative propranolol is now, quote unquote, almost standard of care for most people around the world who actually do Sturge-Weber in young children. So this is a little bit of toehold of contribution from our institute. Okay, congenital primary aphakia. There are some children that really, really make you eat humble pie, and he was one of them. Remember, congenital primary aphakia is characterized by an absence of development of the lens. It's very, very rare. You only see 1 to 5 in 10,000 births, but you have associated abnormalities of microphthalmia, anterior segment aplasia, because remember, the lens is critical to development of the anterior segment. And the clinical implication of this lens being critical is your pediatric ophthalmology colleagues do not like operating in patients less than 6 months of age because there's so much more incidence of glaucoma. And why do you think that is? Because the trabecular meshwork and anterior segment develops till about 8 to 9 months after birth. And the lens is a very, very major regulator. So if you take it out, then you're retarding development of the rest of the anterior segment. The second evidence for that is from your ROP colleagues. Your pediatric retina colleagues now do not like to do a PPL and PPV, which they used to, pars plana lensectomy, vitrectomy. Now they do a lens sparing vitrectomy because the post op, glaucoma was so much because of that same reason. So leave the lens into small children as far as possible. And these poor children don't have the lens. So therefore, their anterior segment don't develop. So this 8-week-old male comes to our pediatric glaucoma clinic. We're very proud of ourselves by then that, okay, we're doing better than everybody else. We go in and thank God this was pre-COVID. And thank God I didn't do bilateral surgery at that time, because he came after a combined trab with trab, 6 weeks, and the eye was gone. And I didn't know what had hit me. I had no idea what this was, and I couldn't believe, and you can't imagine how I felt. But then I went back and searched and reviewed the UBM, and I had done the UBM, but I had not seen that there was no lens, because I didn't know what the mind didn't know, the eye didn't see. I didn't see the fact that there was no lens in this UBM. I thought, okay, maybe it was some artifact or something. The cornea is thin and hypoplastic. The lens is not there. There is hardly any ciliary body. So in a CPA, if you're going to go in, you are going to push that hypoplastic ciliary body into no function anthesis, and that's 100%. And when I actually looked at literature, so the other eye got a limited DLCP. Now he's 3 years old. He runs around with aphakic glasses in the other eye, and that's all that they need. They don't have a lens, so just give them aphakic glasses. Don't try to do anything else. If you think the pressure is high, do a limited DLCP or something, but don't enter the eye. Once recognized, we diagnosed many, many more. Now it's a spot diagnosis from my residents. You look at this, and I'm putting these images out. Silvery hue of the cornea, shining like this. This is what CPA looks like. Do a UBM, do an ASOCT, there'll be no lens. If there's no lens, don't enter the eye. So UBM is similar, disorganized. When this boy came in, we asked, does he have any siblings? They said, yes, he has a daughter, and then the daughter's the same. And these are the 2 UBMs of the 2 children, and they're exactly the same. There's no lens. So this is Dr. Murli from LV Prasad, who's had the heart to publish this. He's the one who said that he's done 9 patients of congenital primary aphakia before realizing what was happening. 9 out of 9 went into thysis bulbi. And he had the heart to publish it and tell the world, do not enter an eye with congenital primary aphakia. And I said, Murli, you're mad. Why didn't you stop at 1? He says, because I didn't understand. So at least by the time I did, I stopped at 1. So please look at CPA. Give them limited glasses. This is what we did to the other children as well. They will look at your mobile phones. They will run around. They will be naughty. But they're not going to be blind. And they're not going to lose an eye. So this is what they are like by the time they grow up. Those are the little boys who I just showed. But then they're okay. They're happy. They're small children. And this is the only thing that they've seen. So then our teacher comes back. And the mother is pregnant. And she asks for the possibility of the next baby. And this time we know what it's like, what it is, but it was FOXC3, and it was FOXC3, and that's what CPA is. And then COVID struck, and she was scheduled for an amniocentesis for the next baby, but nobody would do an elective procedure. And then we found this report, an ultrasound prenatal diagnosis of congenital primary aphakia, also for the residents. It is so important for you to publish something unusual that you see. It is your responsibility to tell the world. Add to literature, even if it is a case report. So this is just a case report. But it gave us direction. So we sent her for an ultrasound, a level 2 ultrasound, transvaginal, showed up lens placodes in the eye. And the only thing I could tell the mother was, I don't know about the rest of the body. But this baby has lenses, so it's not CPA. So those white things are the lens placodes. And this report says you can prenatally diagnose them. So heart in her mouth, she went ahead, and thankfully the little sister is normal. Perfectly fine, because there are lenses in the eye, and she hasn't inherited the FOXC3 variant that her brother has. So we learned to recognize the condition, we learned no incisional surgery, we learned IOP reduction by limited TSCPC using transillumination, and we learned that you can save these children with some ambulatory vision, but you can save their eyes as well. We retrospectively reviewed all our babies. When I don't understand something, I make funny folders, and I put them in. hoping that someday I'll understand. So right now, presently, I have a folder called Weird Iris, because I don't know what that means. They have all funny, funny things. But this was a folder called Query Sclerocornea. And I pulled out all my query sclerocorneas and called them back and did the UBMs. And I found 5 more. And all of them had no lenses, except that when I was putting them into those folders, I had no idea what they had. And thankfully, I didn't operate any of them. So all of them have lenses. So all the UBMs are the same. There's no lens, thin corneas, hypoplastic ciliary processes. So we published that in JPOS, and now most people, most pediatric ophthalmologists do recognize this very well. Right, changing gears again, congenital ectropion UVA diagnosed by Robert Rich, but in older children, unilateral with ptosis. We started seeing this weird phenotype, and this was the phenotype that Dr. Schlagel was talking about, because I saw ectropion UVA, and I saw hyperplastic iris. So we started looking at this and seeing this in some of our babies, and we wondered what it was, but you don't really do much about it. So what we did was we looked at them consecutively. And baby after baby after baby had this weird congenital ectropion hypoplastic iris. We didn't know what it was. It certainly wasn't PCG. And these babies did very, very badly. They were very intractable. Repeated surgeries, the pressure wouldn't come down, the corneas wouldn't clear. And then when we looked at pigment epithelium over the anterior surface of iris with or without iris hypoplasia, and we looked at all our neonatal onset glaucomas, the ones with this congenital ectropion UVA did really bad. So we learned that, and we've now coined this term, and it's a phenotype. It's a separate phenotype now, neonatal onset congenital ectropion UVA. The implication of that is a CYP1B cytopathy, which is a spindle-shaped corneal structure in the center, which does not clear, ectropion UVA hypoplastic iris. And I can confess that when you don't know, you do stupid things. So the stupidest thing that I did was I saw this ectropion UVA. I called in my pediatric retina consultant, and he looks at it and says, oh dear, there's ectropion, and tries and sees the retina, and there was nothing there, and says, okay, but there is ectropion, there must be neovascularization, let's inject anti-VEGF. And we injected anti-VEGF in a baby for no rhyme or reason. Thankfully, nothing happened. But it was when baby after baby after baby came with ectropion UVA, because we were looking for it, I realized there's no neovascularization, you don't need to. So this is not neovascular glaucoma. This is a congenital anomaly. It's called congenital ectropion UVA. And this is distinct from the older congenital ectropion UVA, which is also described, unilateral, ptosis, sometimes associated with neurofibromatosis, very bad glaucomas in one eye. So this is one phenotype, but they're all older children in the 2nd or 3rd decade. This is neonatal onset, bilateral, intractable glaucoma, and with the cornea which does not clear. The next question was, why does it happen? So if you're very questioning, you have to keep questioning yourself. Why does this happen? Let's look at genetics. So then we looked at genetics. Again, we had only CYP1B1. We diagnosed neonatal onset CEU on EUA. We knew these genes happen, but we started with CYP1B1. We took the babies which completed a year follow-up, and we had 13 babies who presented to us in 1 year of neonatal onset. 92% had CYP1B1 variants, and out of these, 83% had the one variant, arginine 390H. So now it was a genetic biomarker of CYP1B1. And now my resident, my first year, comes to me and says, we have an R390H. I said, you don't have an R390H. You have neonatal onset CU, but it's so characteristic now that we don't need to do genetic testing for them anymore. We know it is biallelic CYP1B1, most likely R390H. And this is the spindle-shaped thing I was talking to you about. They come absolutely white, and you do the surgery, and you have the spindle in the center, which is not going to go away. So then we followed up our publication with the genetic variant, and now it's understood that if you have this genetic variant, it is going to be CYP1B1. And the closest description in literature was by Professor Arif Khan, who calls this partial aniridia, and he was so happy that this paper was out, because he says at last people have started recognizing the phenotype and not clumping everything to be just PCG. So This is what the traditional CU was. We looked at our children who have that. We published that as well. So but it's very rare. So out of about 1,421 newly registered pediatric glaucoma patients over a period of about 6 years, we could find only 5. So it's very, very rare. So it's something which is rare enough to be picked up, but it's important to know that there is an older version of this also available, but it's very rare. So this is what they are like. Most of them, as I said, surprisingly, and I asked Dr. Deepak Edward that, why are they all left-sided? So it's something to do with the axis of development or something. He said, but very interesting. Most of them are all left-sided ptosis, ectropion, unilateral glaucoma, but older children, all of them. So now clinical exome sequencing or whole exome sequencing is really an integral part of our diagnostic workup. And I said in the beginning, y'all are very, very lucky to be born into the era of next-gen sequencing, because it's going to make genetic testing so much more easier than what it was like when we started off. So this is just a snapshot of some of the variants that we found. I won't go into the details. I'm sure all of you're lucky enough to have the Paul implant now, but we are stuck with the Adi. The Adi is really our savior for refractory glaucoma in children, because it's non-valved, it's cheap, it's made in India, and it has made the management of refractory glaucoma so much more easier. And this was the first publication of Adi actually, and it was in congenital glaucoma. So we published this way back, but after that, Adi is very much our go-to implant nowadays. But from 350, you have the Adi 250 now, sorry. So the 250 now has made it even better. You don't need to dissect the muscle as much as you had to. It helps the journey. All these children have grown up. You can see this little boy comes as a baby, and he's almost 15, 16 years old now. But I'd like you to look at the visual fields. And this is something which tells you that over a period of 10, 12 years, if you can keep the visual field absolutely stable and you go in when required, then that's something. Now, this boy has an Adi in both eyes, but that's the last surgery that I've done in a long time for him. Steroid-induced glaucoma, we've been talking about it. In India, it's over the counter, so it's a huge cause of blindness. Children come to us with allergy. Their mothers just go to the pharmacist, show them the old bottle and say, give me this. And they keep putting dexamethasone, which is a scheduled drug, which means it is cheap. And so we looked at the outcome of ocular steroid hypertensive response in children. But the most important thing was 38% of them can be reversed by withdrawing steroids only. So if you have a child, the implication of that with even 30 pressures, and the discs are not too bad, don't jump into Combigan, Latanoprost, one cocktail, Dimox also, and then send them. No, just withdraw it. Nothing is going to happen to that optic disc. Withdraw the steroid, just see what happens. Give them 6 weeks of steroid free, the pressures will come down. What damage has occurred will occur. By giving them a cocktail of 5 anti-glaucoma, you're not going to reverse the damage anyway. So just hold on. So 40% of all the children that came to us could be managed by just withdrawing steroids. 43% required 1 or 2 medical treatment, and only 17% required surgery. So be careful of that, but steroid-induced glaucoma is a responsibility of us ophthalmologists, and we are the ones who give them this blinding disease. Having said that, beware of routine steroids. So there's nothing routine in medicine. So this 4-month-old baby, uneventful goniotomy, next day he was fine. So my usual follow-up is 4 weeks later or 2 weeks later. Routinely prescribed steroid drops and called him back. The mother missed the 2-week follow-up, came back 4 weeks later, and this is what happened. And she was so happy. She says, after the surgery, my child has become, I said, your child is sick, silly. What has happened? And what has happened was, despite telling and explaining, you can see missed follow-up, compliance problematic, but no punctal occlusion. So if you're going to give a steroid drop, which is for a 60 kg adult to a 3 kg baby, as it is, your dose is so much higher. And if you are not very, very sure with the mother and the parents to do a punctal occlusion the minute you put in a steroid, the minute you put in an antibiotic, sometimes you might, this is not usual. We do this day in and day out, but I thought it's important to show what can happen. And of course, you want to know why. So he sent him immediately to endocrinology. He was admitted in the pediatrics ward. He was given stress doses of hydrocortisone before the next EUA. 2 months later, the moon phases settled, the parameters normalized. By the time he was 7 months old, we could reverse the iatrogenic Cushing's. The weight was as per age, and the steroids, the hydrocortisone was gradually tapered. But then again, you ask yourself, why? And our patient had a variant in USP11, and it hadn't been reported, but USP8 of the same family is the gene which is responsible for Cushing syndrome. So maybe it was the same pathway. He's already USP11 deficient. You give him an adult dose of steroid, the mother doesn't do a punctal occlusion. This is what happens. So we did tell the world, we did report this. So anything unusual, I always want to share, and I always want to publish it so that people know that this might happen. Acute hydrops is the most gratifying, yes, I am God kind of thing for you, because you will have a child who comes like this, and the mother will be distraught. 2 days ago, he was fine. Now he comes with a white cornea, and you say, don't worry, I'll make you okay. And then in 3 months' time, the eye is fine. So it's really gratifying. So we also looked at why it happens, and you see how much the Hab striae has really expanded, and all that fluid goes into the cornea suddenly. But we had an interesting observation that if you had an acute hydrops in one eye and you did surgery in the other eye, the baby comes back with an acute hydrops in the other. So there is a consensual rise of pressure. And this was the paper where we said that this is at least one condition where you should do simultaneous bilateral surgery. Now we do it in all, because COVID had taught us not to give too much GA and call them in too many times. But at this time, we were doing one eye at a time. So you see, he had left acute hydrops, we did the surgery, left eye cleared, right acute hydrops, and then we had to do the surgery. And multiple babies. We had, I think, 4 children like that. We said that acute hydrops, be very, very careful of the other eye, because there's something wrong with the desmids, which makes it stretch and makes all the fluid comes in, and it comes into the other eye as well. So then, now we are in the era of GATT. So again, you want to try something new. Acute hydrops again. And then the question is, of course, combined trab with trab. This is our go-to surgery. We make them fine. And then on table, I can just about see the angle. And I tell my resident, should we try? So it's in Hindi, you say, try kare. So try kare, and then I'm sure they roll their eyes and says, oh, she's gone mad again. They said, you're not going to be able to do it. Come on. I said, okay, let's try. So we tried that, and that's the GAT. So this was a very interesting thing. So you see, the Habs is right in the center, and I can't see where to go at all. But then I realized that this part is okay. So I changed the chair and moved the microscope so that I can make that first incision in just that part which I could see. And if you can manage to cannulate it without too much trouble at the first go, and you can see that blue thing in the schlems, you think you're good to go. And there you are. So we did manage a GAT in an acute hydrops eye as well. And we were so proud when in the 6-week follow-up, the cornea completely cleared. Without incising conjunctiva, without cutting sclera. And if you can manage to do that, you're even more God than you were in the combined trab with trab. So how do you think children perform in the visual fields? I'll just run through this. What we did basically was match the retinal nerve fiber layer thickness of children with that of the adults, and compared the visual fields that they did between 6 and 12 and 12 and 18. And what we found that the visual field in normal children slowly increases. So in children, the visual field is always depressed compared to adults, even with comparable retinal nerve fiber layer thickness. So don't think that children who you're doing a baseline for actually have glaucoma. Their sensitivity is low. It builds up till 12 years of age, and it's almost the same by 18. So between the 12 to 18 children, you can compare it with a normative data of adult visual fields, but less than 12, it still has time to develop. And I think that's why amblyopia, our traditional teaching was 12 to 13 is your magic age, and then after that it's unlikely to improve, because I think the visual maturation would occur then. So the other thing is, of course, ASOCT. I've showed this in the last 2 presentations, but this is a flying baby ASOCT. This is a novel imaging in-house, so it adds to the eye care, the axial length, and now we have a flying baby ASOCT. If we see trabecular meshwork, may not be, but if we don't see trabecular meshwork shadow, it is likely to be glaucoma. So that's something which is really added. It takes 5 seconds on the swept source ASOCT, and I encourage you, if you have the swept source Cassia ASOCT, to try it in your children as well. So these are what these images look like. You can see the TM shadow here, but no TM shadow there, and this is unilateral PCG. Late onset PCG, no trabecular meshwork shadow in either eye, and with a high iris insertion. I've shown this yesterday again, but congenital corneal haze referred as PCG. Brother has had surgery for glaucoma, cornea hasn't cleared. So the flying baby OCT shows very good trabecular meshwork, and iris inserted nicely on the ciliary body. So even in a 3-week-old child, there's no problem. You just hold the baby like that, and you can take the pictures. So we decided to wait, and waited for the genetics to come, and it was congenital hereditary endothelial dystrophy. Thank God we didn't operate on him, and we've sent the brother for a DSEC as well. Just a few snippets. UBM has been a game changer. This is Axenfeld rigor. That's congenital primary aphakia. I think these images are also very good for the residents to keep sending. It adds to your profile, and it makes your CV a little more colorful. And Peters anomaly, again, on the cover, because it shows the Descemet's defect well. This is something which, again, is novel, is new, intracorneal clefts. And the fact that the fluid can actually form clefts inside the cornea, and if you operate in time, it'll remodel, and it will show up as a scar. And Peters anomaly with a sequestered lens in the center of the cornea. Now, after successful surgery, is your job done? That's the next question. With glaucoma, with adult glaucoma, yeah, you do successful surgery, your pressure's controlled, everything is fine, bye-bye. But 2 months PCG, surgery done, 3 years, cornea clear, IOP okay. But you see how angry this person is. An angry baby, an angry boy. And I used to ask the mother, what is he so miffed at? I said, I don't know, he's always like this. 7 years, cornea clear, IOP okay, still. He's not a very happy kid, is he? Now he's grown up, he's a young man, he's still a little strained. 6'6" both eyes, clear corneas, 14 millimeters, normal discs. I said, what is your problem? What is this? It's strained. I mean, I know it's 6'6", but there's something. And what is something is, he has harbs in the center, in the pupillary area. The poor guy can't see very well because of this distortion and glare. And I asked the cornea guys, what will you do for him? He says, we're going to do nothing. He's 6'6", both eyes. He is 6'6", but I really don't have an answer as to what to do if there is harbs in the center of the pupil, which is not making this patient very happy, because it's a distorted. You can imagine if you have things right in the center of your pupil, what would you do? And I have no answer to what you give, but my job isn't done even now, because he's not very happy, even though I am. So the summary and learnings, of course, neonatal onset glaucoma, PCG has a good prognosis, non-PCG doesn't. Sturge-Weber syndrome, perioperative propranolol is a huge game changer. You can repeat repeated GA by using sedation. CPA, please do not enter the eye. Give them FAK glasses. Even topical steroids can be dangerous in a child. Be careful. UBM is a game changer. Please incorporate that as a routine for all your EUAs. Genetic screening, NGS is possible and aids in clinical decisions. We'll talk about that tomorrow. ASOCT flying babies has made my life a lot simpler. So I'll just show off a bit. Joys along the way. That's the Noel Rice lecture at the UK PGS. That's Ashok. He's joined as faculty now, but he's won 2 Best Paper Awards at UK PGS. Srushti is going to finish her residency this December. She's won it for her thesis this year. Bascom Palmer has honored me as you have, so that was a nice experience. You've just, I think, been with Elena, but I was with Elena before she came here. And at the University of Pittsburgh, again, I had the opportunity to also visit as a professor this year. And that's Manik, my fellow who won the Colonel Rangachari for the Best Paper Award at the All India Ophthalmology Service also. We are not heroes every day, but there's something good in every day, I think so. And the question is not whether we can afford to invest in every child. The question is whether we can afford not to. And I'm very happy to share that the Indian Pediatric Glaucoma Society conference is in Madurai this year in December. I acknowledge all my residents, all my mentors, all my fellows. They work very, very hard to enable me to make a presentation like this. All that hard work is really just names in the papers, but they work very, very hard. Just snapshots of life in India. That's a typical, even our homes are crowded as India is. That's my husband. He's a professor of general surgery. These are my two joys in life, Rohan and Aditi, my children who are both abroad, flown the nest. Mums and dads, both dads have gone up, and I'm sure they're sharing their beer up there. Both mums are still around, all four doctors. Two anesthetists, my mom-in-law and my dad, a gastrosurgeon and a pediatrician. And my daughter's a child psychologist. So my mother has put in the love of children, I think, from a pediatrician to a pediatric glaucoma and a child psychologist. So my greatest blessings call me mom. And now that they've flown the rest, that little fellow is Russo there. He's the only one remaining. These are festivals. Yesterday was Diwali. So I just put this in, that this is what Diwali in India in all households looks like. It's a festival of lights. All houses are lit up, and there are firecrackers and all that. This is Holi. I think Dana was part of Holi when she came to India. Everybody's in color, and she wondered why there are pink men walking around the streets of Delhi, but that's what happens. And this is something called Bhai Dooj, which will come in on 23rd. It's 4 days after Diwali, where a sister ties a rakhi around her brother's wrist, and he promises to protect her for the rest of his life and that. So when they were home for Bhai Dooj, this is what happens. So thank you. No matter how stressed you are, remember how blessed you are. I can't be more grateful for the opportunity and for your invitation. Thank you very much.
Thank you. Thank you very much for sharing not only the hard way in congenital glaucoma, but also your private life.
Yeah.
Any questions? No questions? I was surprised, Dima. I was surprised.
Thank you. So I'm a cornea specialist, and I would like to hear your thoughts about CHED. You mentioned the last case.
Yeah.
So I think given also the high prevalence of consanguinity in India, similar to Saudi Arabia, you would get to see those kind of cases where PCG versus CHED. And I've came across a couple of cases where they were operated for glaucoma or primary congenital glaucoma, however, they ended up being CHED.
Yes.
So do you believe both can coexist? That's my first question.
Yeah, okay.
And my second is that how do you usually manage those cases that get to be in between? I mean, you cannot really make the proper diagnosis from the first sight. Thank you.
The only commonality between the two is the hazy cornea. I have yet to see a CHED with disc, which is glaucomatous. And that's my go-to. If the disc is 0.2, it's not glaucoma. The corneas are usually 1,000, 1,200 microns, so your pressures might be 22, 24, but I'm not sure whether that's fallacious or not. And I have yet to see one of those cases of CHED who were operated for congenital glaucoma whose corneas have cleared. If that was pressure related, it would have cleared. So I don't believe, because they're two different things. SLC411 versus CYP1B1, they're two completely different pathways. And I'm not sure that there's only one paper which says coexistent CHED with congenital glaucoma. But when I really looked at the methodology of that paper, and I was talking with Dr. Khalid regarding that, when you look at methodology of how PCG is diagnosed, it is only diagnosed on the basis of a hazy cornea and high pressure. But that hazy cornea and high pressure is explained by the shed, and it's not necessary. And they don't talk of discs. They don't talk of axial length. So in my experience, I haven't seen a shed with a disc which is damaged. And thankfully, my pediatric cornea specialist is very junior to me, who was my resident, so I can order. If you see shed, look at the disc. So she looks at the disc, and till date, she hasn't found any with the disc which is damaged. So they just go ahead and undergo a DSEC, and they do well after that. So in my thinking, I might be wrong, but in my thinking, they don't coexist.
Also, I think a challenge would be checking the disc. I mean, it depends on the severity of the CHED, but I mean, if the CHED...
I don't think the cornea is ever so white that you can't do an indirect ophthalmoscopy, or at least an ultrasound. You need to have some evidence of a disc cupping. And I haven't found any as yet, but my limited thing so far. That's my thing. What was your second question, sorry? What was shed?
You've already, I believe you've already
Okay,
covered it.
okay,
It's
all
the
right.
like how
Yeah.
would you
Diagnose,
differ?
distinguish the
And
two.
it
Okay,
also,
okay.
the genetic screening also comes into place.
Yes, of course. Genetic and the SOCT now. If you see very, very bright trabecular meshwork, it's unlikely to be glaucoma along with that.